Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on current best practices and emerging applications with CAR T-cell therapy in various hematologic malignancies. This episode is part of a larger educational program titled CAR T-cell therapy, applying the data, tailoring treatment, and future considerations. During this podcast, Dr. Michael Bishop from the University of Chicago in Chicago, Illinois, Dr. DeAngelo from the Dana-Farber Cancer Institute in Boston, Massachusetts, and Dr. Noopur Raje from the Massachusetts General Hospital Cancer Center, also in Boston, will answer audience questions from a series of live CCO webinars on such important topics as the use of approved and investigational CAR T-cell therapies for treating lymphoma and leukemia, sequencing CAR T-cell therapy with autologous stem cell transplantation and other treatments, emerging CAR T-cell approaches for myeloma, and optimal management of CAR T-cell therapy-related toxicities. For more information on our expert panel, along with a link to the complete program, including downloadable slide sets, please visit the notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
I'll start with Dan. And so, Dan, where do you think, where is the greatest need right at this point with CAR T-cell therapy for acute lymphoblastic leukemia, either in adults or in children?
Well, clearly, Mike, we don't have an approved agent in adults. So, I think that's really where the unmet need is in trying to work out the toxicity profile. As we mentioned, the JCAR study closed and halted because of toxicity concerns. The Zuma trial, fortunately, has been able to proceed both in the phase 1 and in the phase 2 study, and hopefully that'll lead to an approval, which will really set the stage for the first CAR T-cell in older adults. The Ileana trial, or DeAngelo, is only up to age 25, and so we're really in quite a bind right now in the adult setting for patients 26 and older, where we don't have a CAR T-cell outside of a clinical trial. And then the next unmet need is trying to do one of two things, right? Trying to deal with the CD19 negative relapses. Is it CD22 positive or these bispecific CARs, as both of us discussed? And the other issue is to try and move it up. As we all know, the earlier you treat relapse, the better it is, regardless of the disease. And that's never more clear in ALL.
Excellent. Noopur, I'm going to turn to you about multiple myeloma. On relative to what we've seen in leukemia and lymphoma, and again, these are anti-CD19 CARs, we do see that there are a significant number of patients who achieve complete remission with multiple myeloma, but we haven't seen that plateau and flattening of the curve. And I just wonder if you have some ideas why that might be and how we might make, if we may see that in the future with different CAR constructs, or just any ideas that you may have relative to that.
Yeah, so, obviously what we've shown so far, Mike, is a very relapse refractory patient population where typically they wouldn't live beyond 6 months. And for us to be able to see patients who achieve a CR actually live close to 20 months is one step forward. But you're absolutely right. There's no flattening of the curve there. And potentially two reasons there. One, I do believe it's a biology driven issue, because up until now, we've always used continuous therapy for myeloma. We use maintenance. We always have patients on treatment. And this is the first time that we are doing a one-off strategy and stopping after the one-off strategy. And myeloma may require something like a maintenance strategy post the CAR T cells. The other issue is maybe if we have a really potent CAR which actually persists and is able to control the disease burden over time, we may not need to do that. So doing CARs earlier on in the disease paradigm is probably needs to be tested, and we are doing those trials as we speak. So no good answers right now. Our hope is that we start seeing plateaus like the lymphoma and leukemia studies do.
And in follow-up, and this is an open question to both of you, there's been a lot of question relative, and it kind of falls into that where you have patients so heavily pretreated, particularly in multiple myeloma, about T-cell function. And this appears to be, when looking at T-cell health and persistence after related to outcomes, there does seem to be a correlation in all diseases. And I was just wondering if either of you or both of you could share what your thoughts relative to what we might do, and be it treat patients earlier, or is allogeneic CAR is going to potentially be the answer?
So I can start. I think what I was pleasantly surprised by, Mike, is that at such late stage myeloma, we're still able to actually generate a CAR which gives you MRD negative disease. What we are studying right now is what the best time to actually generate CARs would be. And it is potentially possible that collecting these CARs earlier, before they see all the kinds of therapies that we give our patients, may be the way to go. But I'm actually most excited about an allo CAR. So an allo CAR for an initial response, and maybe follow that up with an auto CARs, which may persist. We have no data to speak to that, though.
Okay, great. Dan, any thoughts?
We've been able to generate CARs, just like Noopur mentioned, even in late relapses post-transplant. So, I'm a little bit less enthralled with the allo CARs, Noopur says, because we just haven't seen a lot of persistence. But maybe there's some avenue in the future.
Do you believe that CAR T-cell science will evolve to overcome sources of resistance in CLL?
Yeah, so that's a super question, and and it goes back to two things, and it really does go back to that T-cell health, because CLL actually has some of it's just inherent when you at diagnosis, the T-cell health is very, very poor. And if you notice when I was showing those slides, after ibrutinib treatment, those patients who had a prior ibrutinib therapy, they appear to do better. As a matter of fact, there is data showing that ibrutinib can actually improve the health of T cells. So I think that's one of the more important resistant mechanisms. And on top of that, so CLL has a slightly lower expression of CD19. So I do think that that's actually going to happen. And as a matter of fact, a large degree of investigation is in regard to improving T cell health. And I think that's one of the biggest reasons that we see variability in terms of response and in durability of response.
Dan, there's a question for you. In pediatric ALL, loss of CD19 target is a problem. Per Dr. Bishop's presentation, can you also target CD22 to mop up the escape variants?
Yeah, I mean, I kind of addressed that a little bit in the bispecific CARs that are trying to do that to try and focus on inhibiting the CD19 relapse, which interestingly hasn't been completely successful, because you're still seeing CD19 negative relapses in these bispecific CARs, both the ASCO update as well as the ASH, arguing that in the CD19, CD22 composite or bispecific CAR, CD19 is primarily the driver. But there are some CD22 only CARs that can be used in CD19 negative relapses. So that would be a second CAR after the first CAR the first CAR failed the patient. And so those are both alternative strategies. So the simple answer is yes, but different methodologies are currently being used.
Great, thank you. There's a question on CRB401, which is for me. Are CRB401 results independent of genetic type, including 1416? The answer to that is yes, it's independent of genetics. But having said that, folks with high-risk genetics actually relapse a little bit faster. Response rates are independent, but persistence of response is still a problem in that high-risk patient population.
There was an interesting question, Noopur, on anakinra. What is the role of anakinra in your practice, dosing and duration? Did you want to touch base on that again?
Sure. So, we haven't seen a lot of HLH in myeloma. We've seen it once or twice in our patients, and we've seen some neurotoxicity. So I've used anakinra rarely, and we typically use 1 to 2 mg per kg, and we've given it for 3 or 4 days, either Q day or twice a day, depending on their renal function. So have
Yeah.
you
So I have a patient where we're using it right now. So we see a lot more HLH-like features, and it's hard to know if it's really truly HLH or just a CAR phenomenon because you don't see hemophagocytosis, and so you see a kind of a hodgepodge of it. But in those situations, we have used anakinra either with steroids or without, and we try to use it twice daily for 3 days. Depending upon the renal function, but it's remarkably effective.
Yeah.
There's one question here, and this is about for patients eligible for autologous stem cell transplantation, do you advise BMT, and if relapse CAR Ts or CAR T cells first in relapse? And so for patients who are eligible, and what would be defined as having chemotherapy sensitive disease, we do recommend transplantation first. And really even patients who are with PRs, they would go to transplant first. And I think that's the case in myeloma as well. If Noopur, if you want to address that.
Yeah, no, as of right now, I think the autologous transplant is still considered standard of care for myeloma. So most of the patients who've gone onto the CAR T-cell products have been post autologous transplant relapses. Having said that, we do have a couple of trials which are ongoing, and these are for high-risk patients. We are taking high-risk patients to an auto CAR even before going to an autologous stem cell transplant. Very early days with that, no data as yet.
And so here's a neurotoxicity. So Noopur, if you want to do this, do you think ciltiximab is better than tocilizumab or neurotox?
So I think, it makes sense theoretically because ciltiximab obviously is not an IL-6 receptor blocker, and if you believe that IL-6 is what's causing the neurotoxicity, we don't completely understand the pathophysiology of neurotoxicity. It is thought to be related to part of it may be IL-6, part of it may be cytokines, part of it may be T cells crossing the blood-brain barrier and the endothelial system, which is allowing the blood-brain barrier to become more porous. So we have not yet started using ciltiximab. There is an ongoing study where we are going to compare ciltiximab with tocilizumab. So theoretically, yes, possible that ciltiximab is better.
So what is the relationship? And again, this is to everybody because I know the data is variable. How's the relationship between T cell expansion and persistence and efficacy and duration of response? Dan, do you want to start?
Sure. I mean, at least in the pediatric and the adult ALL, that if you don't get expansion of your T cells and persistence of your T cells, this leads to either loss of efficacy or early relapse. And in the Ileana trial, interestingly, even beginning with the Penn studies, the single institution studies, they monitored this with immunoglobulin results. So, if it's a CD19 CAR, so you're wiping out both normal CD19 function as well as hopefully the disease. And in patients who had normalization of their immunoglobulin levels, these patients oftentimes would have relapsed, arguing that they had lost persistence of their clone. So at least in ALL, there seems to be this one-to-one correlation with the tezencicleucel. That may not be the same with every CAR product. In Zuma, that wasn't the trend. We didn't see a lot of normal B-cell dysfunction, at least to the degree that we saw in the Ileana. I'm not sure, Mike, your experience.
Yeah, so I mean, you segue perfectly what I was going to say. I think it really is dependent upon disease and actually the construct. So if you look at Zuma 1 versus Juliet, in Zuma 1, it was really the expansion within the first 28 days, and persistence did not really affect duration of response. It affected response, overall response, but not duration of response. In contrast, Juliet, which uses a 4-1BB as opposed to the CD28 in Zuma 1, early expansion wasn't that, I mean, expansion was important, but it didn't directly correlate with response, and persistence did, although not absolutely. So I think there is great variability relative to disease, the target, and the co-stimulatory domain. And you want to comment about that relative to myeloma, Noopur?
Sure. So, the good news in myeloma is we have just the one target that we are studying, and all of them have used 4-1BB. But we are beginning to see differences. And if you think about ide-cel, for example, there is definite correlation with expansion and persistence, so that if your cells are persisting, your duration of response is longer. But if you look at the J&J product and look at the CARTitude studies, you see a very high response rate to begin with, and their T cells do not persist beyond 8 and 10 weeks. Now, we haven't had the long enough follow-up, so whether that dual biepitopic binding is enough to cause that initial kill without necessitating the persistence of these T cells, we'll have to wait and see. But the kinetics of both of these products are very different, and we do need to see the follow-up on the CARTitude study for that reason.
This comes back to the lymphoma, is in a similar patient population, how do you decide which CAR T-cell therapy to use? And that is the million-dollar question. There are a lot of times it will be whether or not the institution what they've been approved for, because each institution has to go through a very thorough vetting process for whether or not they're able to administer that CAR T-cell product. Now, I can give you anecdotal information, because University of Chicago was actually the first center which was approved for both products. When you're really worried about toxicity, we may choose a product with a 4-1BB co-stimulatory domain. And then with patients with more aggressive lymphoma, we may lean towards a CAR T-cell product with a CD28 co-stimulatory domain. However, the bottom line is, at least for me, is what is the efficacy? So if you have something with equal efficacy, you're going to lean towards the one that has the least amount of toxicity. And I can, so hopefully that answers that question. We do notice different CRS rates among different CAR T-cell targeting the same antigen. Is it due to some binding of different epitopes or some other mechanism? So I'll turn it to my colleagues to respond to that.
There's different CRS rates and neurotoxicity rates dependent upon the disease. I think both lymphoma, leukemia, and myeloma, you've seen different results. And you see different CRS and neurotoxicities with respect to the targets as well as the product, whether there's a 4-1BB or CD28 co-stimulatory domain. The other thing, at least in my field with ALL, is it's different amongst kids and adults. So, we're seeing a lot of differences in terms of the approaches and the different toxicity profiles. I don't know if Noopur, if you have anything else to add.
No, I totally agree with you, Dan. The only thing I would add is, at least in myeloma, it does correlate with disease burden as well.
Yep.
And depending on the product, higher disease burden, we do tend to see higher CRS for the obvious reasons. One of the things which we are looking into is the T-cell fitness prior to doing the CAR T-cells. And the more robust the T-cell, the more robust the T-cell expansion is going to be, and the higher the CRS rate is, which is where you're seeing these subtle differences in terms of disease versus patients.
Yeah, that's a very good point, because clearly disease burden influences that. And one of the things with the JCAR19 trial when I presented at SITC a couple years ago, is that the 5 neuro deaths, they were all cerebral edema. It occurred in young patients. And when we looked at it retrospectively, these are patients who had really robust T-cell activity. And the older patients, the patients with more that were more heavily pretreated, tended to have less healthy T-cells and therefore less cytokine release syndrome, less neurotoxicity. So it was the opposite of what you may have expected. But if you think about it, the patients with the more robust T-cells are the ones that had the toxicity. We're not seeing that type of toxicity, at least in the ALL, with the current trials, thank God.
Why is there less high-grade neurotoxicity in multiple myeloma CAR T-cell trials?
So fortunately, we've seen very little in terms of immediate neurotoxicity, and I do think all the myeloma trials have used 4-1BB as a co-stimulatory domain. And as mentioned earlier, when you have 4-1BB, the rate of expansion is a little bit different compared to CD28. CD28, you get a pulse of expansion and then maybe petering off. We've seen a more gradual expansion. Whether that has got something to do with neurotoxicity and crossing the blood-brain barrier and endothelial impact, I don't know, but that's the hypothesis.
All right, very good. And staying on the theme of toxicities, there's a great question here from Eduardo. Which is the mechanism of cytopenias? I think that's a really important question. And I'll let you. Well, I'll give you my crude assessment, and I'd love to hear my colleagues' thoughts on this. And I mean, often we don't know, to be blunt and honest about it. And I'll give you, again, another anecdotal situation. I have a patient now, she's over 3 years out from CAR T-cell therapy and in a complete remission. And her hemoglobin, actually the last one I just saw was 15, and her platelet count is over 400,000, yet she struggles to maintain a neutrophil count. And she lives, her quality of life is outstanding. And I don't know what this is, but this just shows you how these cytopenias can be. And she's still making 200 to 300 neutrophils on her own, but she needs that shot of GCSF to keep them up. And I mean, part of the mechanism is people are believing that something happens in the marrow, B lymphocytes, and it's a constant stimulation, and it's a bystander effect within the marrow. But at least to my understanding, this remains an unknown determinant of what that caused cytopenias. And I'd be glad to hear everybody else's opinion.
Oh, I agree with you, Mike. I don't think we know. And it's a small subset of patients, very occasional patient who has that protracted cytopenia, but they do exist. And like you said, it's just one cell line. It doesn't have to be the others, and it's completely unclear.
It seems to be less common in ALL for whatever reason, but it's got to be some type of bone marrow milieu and cytokine mediated, because although you can find the T cells in the biopsy, but they're just not. It's not a myelocystic process. It's not like they're pushing out the T cells. The neutrophils. And as you mentioned, most of the time the other cell lines are normal. So it's got to be a cytokine mediated process.
Yeah, I mean that's what I think so too. So and again, we know that cytokines can be hard on marrows and everything else. So I think the fact that these patients, the long-lasting ones, are probably having ongoing persistence of cells, and that very much be it. And closing out our talk on toxicity, and I'll throw this out to the two of you. Can you talk about delayed ICANS in patients? And again, Dan might want to start with you, before ICANS plays a significant role in ALL.
Yeah, I mean, it's to be honest with you, it's been reported. I haven't seen it much in my own patient population, but the times that I've seen it most, or at least heard about it most, are in older folks who've gotten it. But I honestly don't know the the mechanism of that either. I don't think we really understand. Maybe you guys have another things. Most of the time, my patients have had this gradual improvement over the course of time, and then have got normal. They may complain of a few symptoms, but they're really not are negligible. Maybe you guys have other experiences than I.
So
Go ahead.
we have seen some delayed toxicities with certain products, and those are very delayed, and it's still unclear as to why that is, and that's way 3 months out. The other, I think, important thing to
Was that their first presentation, Noopur? Is that is that their first presentation, or they had early neurotoxicity that just continues?
No, it's just delayed, very delayed, and it's not quite related to fludarabine toxicity. We still don't understand that completely, and that happens around 3 months or so. So that's something which we are studying as we speak. And again, it's not related to age or disease burden, so it's very unclear. The one thing I do know, though, is because for myeloma, we tend to use BCMA as the target. BCMA is actually expressed on brain cells. So if you have CARs which actually cross the blood-brain barrier, you may be causing problems. The other thing, I think we also have to keep in mind is we are using fludarabine in older people without completely normal kidney function, and fludarabine-related neurotoxicity is a real issue, which typically happens 2 or 3 weeks into the CAR T-cells. So it may not all just be CAR T-cell related, but fludarabine may be contributing to some of that as well.
Yeah, I think that's a very important point. And here, we're going to a little bit more disease specific. This comes from Jane, and this is for you, Noopur. The EVOLVE trial, lower dose population had the highest overall response rate. What was that due to adverse events in the higher dose group?
No, so that was a good observation on a slide, which I flipped through quickly. But I think what we've seen with CAR T cells is we see an immediate response within a month and a half, but we continue to see responses, and the higher doses have not had that much of a follow-up as yet. So I do think they're all going to even out eventually. It's not because of increased toxicity. It's just that the median follow-up of duration of time after the higher dose is a lot shorter.
All right, very good. So we have one final question. This comes from Lynn, and I think it's a great way to close out today's session. And it's how long will it take for allogeneic CAR T cells to be effective? What needs to be done? And Dan, I'll turn that first over to you, Dan.
Sure. I mean, this is having taken care of a couple AlloCAR patients as we speak. I mean, the first thing is you need to figure out how to have persistence of the CAR, or at least a little bit more persistence. What we're seeing is trying to figure out, what the dose is and how to figure out. I mean, one of my friends reminded me is it's taken millions and millions and millions of years to human beings to develop their immune system. To think that we're going to be able to come off the shelf, put a CAR in a patient and have it be effective, expand and persist for a period of time is, it's going to take some time. What's the lymphodepletion? I think with Flu-Cy is not working out. In the UCAR19, they had to add alemtuzumab in order to more immune suppressed to get more persistence of the CAR. These are short-lived, oftentimes just enough to get a disease response, and then you move on to an allotransplant. But I think we're still trying to figure out how to get these CARs in, how to get them active and persist and multiply for a period of time. And is it the dose, or is it the lymphodepleting conditioning regimen, or is it both? And those are ongoing clinical questions.
Yeah, so I can just share I very much agree with you. I think we're really, I think the biggest thing, and maybe I get your all comment, is with CAR T cells, we never assume. I saw in the very beginning people try to project what they learned with conventional chemotherapy and even immunotherapy, and I don't think you can do that. And I think that story, it's taken millions of years for our immune systems to look what's foreign and what's not foreign is exactly right. And it does appear, both your observation is very good, is that it does take a significant more amount of immune suppression. And it's just not clearing immunologic space. It's actually severe immune suppression, so these cells won't be rejected. And it's very few of the allo CAR T-cells to date where you see persistence beyond 6 months. And most of them, if you get beyond 3 months, it's remarkable. And it does appear to be cell dose dependent in most of the trials, unless they're giving severe immune depletion, because I think the cells are being eliminated. So, quick. So I do think it's going to take time. I'm very bullish on allogeneic CAR T cells. Maybe that's going to change. Maybe I'm projecting too much. But I do think that I see there's been some encouraging results and initial responses, and it appears to be once you get up to those higher cell doses. So I'm excited for it, but I really do think it's going to take a while before we see them to be clinically effective like what we anticipate.
Well, I hope you're right. I'm not as excited with my experience.
Oh, that's good. All right. Well, this has been great.
Thank you very much, Dr. Bishop, Dr. DeAngelo, and Dr. Raje, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, CAR T-cell therapy, applying the data, tailoring treatment, and future considerations, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the notes. As always, thanks for listening.